Key quality measures by practice provider. Actual performance versus targets by Blodgett. Overview of the situation. Core quality measures were developed by the Centers for Medicare and Medicaid Services, as well as national insurers and employers, and those are being monitored as the U.S. moves towards a value-based reimbursement system. Providers and practices who do not meet these predetermined targets will be reimbursed at a lower rate than those who meet or exceed these targets on these core measures. Background of the situation. Each practice in this organization, as well as the physicians, are having varied success meeting quality measure targets. There is a need to identify those practices and providers who are meeting or exceeding these targets. Goal is to expose these practices and physicians who are not meeting performance targets, as well as recognize those who are meeting or exceeding targets. What is the best way to do this? Through quality management activities. The first step is measurement, which is what we are doing here today. Then there will be an assessment, and finally, there will be improvement. This process is a cycle, so at the end of the improvement part of this project, we will return to the measurement step and relook at some of the visualizations that we look at today. According to staff, measurement defines how we are doing, and we use a process measure. This is used to determine whether the delivery of services are being performed satisfactorily. Therefore, in this presentation, I'll be using visualizations to compare current performance against these predetermined target measures of the core measures. In order to do this, we will rely on data in the database that has been collected since 2014 across 12 practices and 83 physicians who work in these facilities. The database also collects aggregated patient data related to 51 performance measures, some of which are generic, like fall screening, or whether or not a patient got a flu shot, or directly related to a diagnosis like cardiovascular health or diabetes, or even both. For each of these 51 measures, each provider has calculated a rate of compliance for each month that are associated with the practice. For example, there is a calculated rate of influenza compliance, so the number of flu shots given divided by all the patients who were seen that month who could have had their flu shots. So they hadn't already received their flu shot, they have no allergies to the flu shot itself or any components like eggs, they don't have any pre-existing conditions that would prevent them from receiving the flu shot. There is a lot of data to process and a bit too much to take on at one time, so the data needs to be narrowed down further. The first step was to look at target measures. As I said before, we are looking at process measures and how they are doing compared to the target. So we need a target level to help us determine if the organization is satisfactorily performing compared to a target number. Therefore, any performance measure in the database that did not have a target value associated with it was eliminated. That left 36 performance measures. Also, the old data was eliminated, keeping only the most recent 2016 and 2017 data. That will paint the most accurate picture of how the practices and physicians are doing right now. In addition, providers who do not have data for the last 6 months were eliminated since they've left the practice, and there's no value looking and keeping their data, which would either artificially inflate or lower the practice compliant rate, and they will not be included in any future improvement project or future measurements. This means Baldwin, Orient, Fort Fairfield, New Portland, and Allagash were eliminated. In addition, any provider that didn't have at least 3 months of data were not included. That included 4 providers that had 1 data point: Fairfield, Garland, Eagle Lake, and Damariscotta, since you can't get a trend from 1 point. Finally, one needed to narrow down the measures to 5, a much more manageable number for a quality improvement study.
According to a study by Kim et al. In 2019, there are 7 cardiovascular health behaviors and factors that, when in an ideal range, were strongly and inversely associated with the risk of developing clinical cardiovascular disease and mortality. These included not smoking, blood pressure control, total cholesterol control, and a healthy fasting glucose level. Based on these recommendations, I chose 5 cardiovascular health core measures that related to these. One was assessing patient smoking upon an encounter at the office, checking for bad cholesterol, checking the HbA1c, which stands for hemoglobin A1c rate, which measures the average glucose level in a patient's body over the last 3 months, which is a key indicator of glucose control. Blood pressure checks, so checking your blood pressure of your patients and making sure that the blood pressure is controlled, so less than 140/90 for those patients who are diabetic. Now that we've narrowed down the data, it is now time to look at some visualizations to help each office and provider understand how she is doing compared to these target numbers. This view of the data shows the average rate of compliance for all core measures by practice compared to the average target, which is that red line. As one looks at this view, one can easily see that only 4, Aroostook, Cumberland, Knox, and Oxford, out of the 11 practices, have average compliance rates for these 5 core measures that are above the average target rate. However, this does not tell the full story. To get a better idea of how improvements can be made, one needs to drill down the data more. The first graph shows blood pressure control at a level less than 140/90, so the patient's not hypertensive. This visualization shows that for this category, all the practices are meeting the target compliance of 75%, which is the dark blue line. Just because the practice is meeting the target does not mean that all the providers are. Drilling down, this heat map shows that there are only 2 providers who are not able to meet this target rate down in the lower right-hand corner. LaGrange and Camden. Palermo is barely meeting the 75% rate, but if reimbursement were based on meeting this target, all practices would be reimbursed at the high rate. However, there is an opportunity for LaGrange and Camden to improve since they themselves are not meeting this target rate of 75%. The next graph, this one, shows the compliance for cardiovascular patients to have their blood pressure taken during an office encounter. The target value is 90% and is represented by this dark blue line. Again, the blue bars show that those that meet or exceed this target. On the other hand, there is one red bar, unlike the last one, Hancock, which is the only office who is not meeting the performance measure, which is in red. Looking at the provider heat map, there are 3 providers who are not compliant with blood pressure checks: New Canada, Machias, and Danforth. The legend indicates that the darker red Danforth is the least compliant, but Machias and New Canada are also not meeting this target rate. The next category is hemoglobin A1c testing, again, which measures the average blood glucose in the body over a 3-month period. The blue graph is formatted as the previous ones. The blue bar shows those that have met the target rate, which is represented by the blue line of 90%. And this shows that only 4 practices are meeting or exceeding this target testing rate. All of the others are not. Nope, 5. 5 are not. The provider heat map shows a similar story. Although there are some providers that are clearly exceeding this target rate of 90%, most of them are barely passing the target, represented by this brownish green color. And these, the rest, are not passing at all, the reddish ones. So there's a lot of opportunity for improvement. This next graph shows that the number of patients that have had a smoking assessment completed during an office encounter, only 2 have exceeded their 85% target rate. There are 3 practices that are close to reaching that target, about 80%. The remainder have a lot of opportunity for improvement, like Franklin and Penobscot. The heat map also shows that there are many physicians that are compliant in assessing smoking upon encounters, over here. But there are many more practices that are hardly compliant, like Machias, East Machias, and Rangeley. The final graph looks at compliance for cardiovascular patients versus performance target, which is 85%. Again, just like the previous graph, there are only few practices who are meeting or exceeding the target, represented by the dark blue line. The provider heat map shows a lot of opportunity, as a lot of providers are not meeting the targets. Again, Machias, East Machias, and Lakeville being the worst offenders and furthest away from meeting that target. The next step is assessment. On average, the practices are not hitting the average target values for these core measures. Less than half of the practices are hitting these average target values. There are 2 measures, blood pressure less than 140/90 and assessing a patient's blood pressure during an encounter, where most of the practices are meeting their targets, and most of the physicians as well. There are those few providers that should look into either how their data is collected or their routines, and could improve their rates to make sure that they comply better and would improve their reimbursement rates. The measures with the largest opportunity for improvement are the smoking assessment and the LDL cholesterol. For these 2 key measures, 2 groups have emerged, meeting or exceeding targets. This group should work together to develop best practices that they can share with other physicians and practices across the organizations. And the other group is underperforming. They need to identify barriers to performance and use best practices from the other working group to identify strategies to improve performance and meet those targets, and therefore increasing reimbursement. Data needs to be continued to be collected, and in 6 months after the changes have been implemented, the same quality management process, including the same visualizations and assessments, should be repeated to make sure the changes have been adequate and they are closer to the target goals.